families, and the multitude of investigators, study coordinators, and study teams and nurses who cared for these patients. Thanks for your attention.
Paul, great work. Very nice study. I was especially impressed with some of the single organ responses. Very, very impressive. One question. There are a number of things, of course, that we use for chronic graft versus host disease. And it's been many people's experience with ruxolitinib that you can really it's very difficult to wean patients off of it without a flare. What is your experience with ibrutinib in pediatric patients? How long do they stay on it? If you wean them off of it, do they just end up going right back on it again? And when you're done commenting to that, because I'm just very curious, if you can get your patients off of it reliably, when they're treated with ibrutinib, when do they get B cell function back?
So I missed part of what you said with the mask about
Sorry about that.
Did you say something? You mentioned something about ruxolitinib and I didn't catch
that.
That.
Just that I can never get my patients off Rux.
Oh, you can never get it off it. Yeah. Okay.
You know, they just, they respond to Rux, they go off Rux, they fail, they go right back on Rux. Is it the same with ibrutinib?
Well, of course, your question begets 20 more questions from me, but I think in chronic GVHD land, when you look at this cohort, right, most of these patients were steroid refractory treatment resistant and they've failed up to 12 therapies.
Yep.
These patients by definition tend to take a long time, no matter what you find as the secret sauce that finally gets them to respond. I find that it's an incremental process, taking them, first step, get them off the steroids, wait. And some of them have to go back on, some of them don't. But I think the natural history of the GVHD that I always talk to patients is it's going to burn out, but I can't predict. And in this category of patients, they've probably already exceeded the median of 2 to 3 years, depending on the stem cell source. Mm-hmm. So I don't know that I think the answer is generic for whatever you put them on, whether it's ibrutinib, ruxolitinib, et cetera. Mm-hmm. I'm sorry, that's maybe not a satisfying answer, but
no, it's just
my honest one.
Yep. How about the B cell function after you get
the B cell function? I mean, there was no correlative data that was analyzed in this primary analysis, so I don't think we know. But I mean, it's not going to be like rituximab where you take out those B cells you must have had patients like me where they might have got up to 8 doses of rituximab, and sometimes you're still looking for B cell more than 18 months later. So I think it's different in that regard.
Paul, great job with this, what must have been a Herculean effort, as you said, pediatric, chronic GVHD, multiple countries. A quick question for pulmonary responses. I meant to ask Carrie Kitko this question when she presented a couple of days ago. What was the definition for response for the pulmonary GVHD patients? I know it was only a handful of patients, but I think it's important for us to know, particularly in a pediatric age group where PFTs might not even be doable.
Yeah, I mean, you hit the nail on the head. And I think, of those patients that had pulmonary GVHD, I asked the very question from the analysis as well. And it was about, I want to say there were 26 who had PFTs, if I recall, and 18 of them were the FEV1 was less than 80. Now that's not the whole 9 yards for an NIH diagnosis, which is the problem in peds, right? There's nothing about the ratios, nothing about residual volume. So I don't think in current state, the way we evaluate pediatric small children with lung GVHD, you can be super confident about all of that until we get better diagnostics, whether it be handheld spirometry, multiple brush washout, everything that's going to be tested on the Transpire study. If we all participate in it, maybe we'll land on a technique that we can really be more clear on that. But you raise a very valid point.
Janelle Boyle from UCSF. I'm wondering if you can go back to the time concentration profiles really quickly and compare the younger children to the older children. So the blue line reflects the median of the patients or the adults?
That's the adults.
Okay, so it's still significantly higher probably than the younger kids. And I'm wondering if there was any opportunity for further dose escalation, particularly in, the kids who are maybe between 2 and 4 years of age, where they're just kind of plowing through this sort of medication.
Yeah, I think, so again, you've got the foibles of a pediatric study where So in that first dose finding, right, there were at least three. I can't remember how many actually were in that 1 to 6 range now, but it's a small
Very small
number.
usually.
I mean, I think these are box and whisker plots, right? So I think if you look where the median of those boxes are, it's in the lower range of the adults, but it's not wildly out of it. But I think you're right. You could maybe in a bigger cohort attempt to push it higher. Yeah, it's a good point.
Great study, Paul. Ned Waller.
Hi.
Let me ask a variation of the same question, but in a different way. These results are somewhat better than the adult registration trial. Obviously, it's different group of patients, but do you see any suggestion that the younger patients actually respond at a higher rate? Do you see any age as a covariate that's significant here?
Yeah, it's a really good question. I don't know that I mean, the sample size for the very, very young ones is small. I think, I don't think that was something that could be.
But even stratifying by age 10 or something.
From 10. I don't think, I'd have to go back and look now. I don't think there was a difference.
We'll take one more question.
Hi, Brenda.
Hi, Paul. Very nice work. I just want to go back to the previous point. If you look more deeply along with PK experts, I do agree that there is room for improvement in the younger patients. And maybe in the next study, you can see the dose escalation, and especially if you stratify according to age, since you don't have the Lee score,
Right.
The older patients did respond better, but we don't know what the younger one did. But if you see lower response, this definitely we should aim to go higher.
All right. Thank you very much, Paul.